Board of Commissioners' 9th budget work session. Commissioner Shannon Singleton is attending virtually this afternoon. Audience members, I want to start by asking you to please silence your electronic devices. And for those presenting today, please turn your mic on when you begin speaking and off when you've completed your remarks. And for all presenters, don't forget to state your name for the record before speaking or responding to questions. So we are continuing with our multi-day health department presentation this afternoon with our behavioral health division. So with that, I will turn it over to Rachel Banks, the health department director, and our illustrious panel.
Thank you, Chair. Good afternoon. Good afternoon, Commissioner Moyer, Commissioner Jones-Dixon, Commissioner Singleton, wherever, and Commissioner Brehm-Edwards when you get here. For the record, my name is Rachel Banks, and I'm going to start adopting this now, your friendly neighborhood health department director, all of your neighborhoods also. And I'm here today with this fabulous team of folks in our behavioral health division who are going to walk you through obviously a number of things with the budget. One thing I just want to start up top with saying with this budget is these folks have done a really good job and had a hard task in front of them because of some of the changes of the county financial assistance agreement, the state agreement with the, or the agreement with the state, which you've heard us talk about a number of times, which really necessitated taking state dollars from a variety of different categorical program offers as they had been many, many years in the past and concentrating them in priority populations, and then reshifting general fund and other fund dollars around, doing that all while there are other reductions. So this has a lot of little fun, not fun, pieces in it, but we're happy to get started. So I'll kick it over to you, Anthony.
Good afternoon, Chair and Commissioners. My name is Anthony Jordan. I'm the Interim Director of Behavioral Health. I'm joined by my Interim Behavioral Health Deputy Director, Jessica Jacobson. I'm going to start off by saying today we're going to present our proposed FY27 budget. We're going to cover the roles and responsibilities, our budget approach, and the challenges and proposed reductions. Before I get started, I want to acknowledge that there's a lot of interest in behavioral health, and rightfully so. Behavioral health remains a critical issue in our community. In my 30 years of experience, I've seen progress, but significant work remains. This budget balances statutory duties and equity priorities with fiscal responsibilities, aiming to reduce preventable deaths and high-cost health care for acute behavioral health needs. Next slide. The next one. We're in the wrong one, I think.
Wrong presentation.
Yeah.
Go maybe one more slide. I think you're right.
There we go. The next slide.
Yeah.
Okay. The county has several statutory responsibilities. One of them starts with you, the board, the local mental health authority. You are charged with determining the local mental health needs and adopting a comprehensive local plan. The health department functions as the community mental health program, also known as CMHP. The behavioral health division is responsible for planning and delivery of those safety net services for individuals with behavioral health needs. As the CMHP, there are some key services that we are responsible for. Conducting civil commitment investigations and evaluations, supporting our aid and assist population through the legal process, and reporting status updates to the courts. We are responsible for working with the individuals under the jurisdiction of the Psychiatric Security Review Board, also known as PSRB. We ensure that individuals being released to the community are in compliance with their conditional release plan. Those three services are the sole responsibility of the county behavioral health. We are also responsible for ensuring that there is access to mental health crisis services around the clock, including mobile crisis response. The goal of these services is to provide immediate support to individuals in crisis and to mitigate the needs for hospitalizations or jail. There are other required services outlined in our County Financial Assistance Agreement, also called the CFA. However, those requirements are subject to the availability of funds. We'll talk more about that as we move through our presentation. Next slide. You have seen this slide before. But I want to say our system and individuals who move through this system is really highly complex. We have to rely on critical partnerships to ensure we meet the needs of our community members and that we fund these services. Some of our key partners are the Oregon Health Authority and our coordinated care organizations like HealthShare and Trillium, who supports us in bridging system gaps, dismantling regulatory hurdles, and enhancing the delivery of care. For an example, you know that the CFA was imperfect. So we continue to work with OHA and other CMHPs across the state to improve our CFA agreement to reflect our community-specific needs and to secure the funding required for those services. Our CCO partners collaborate with the county and various health systems to facilitate service reimbursement and to drive improved health outcomes for Medicaid members across the Tri-County area. Additionally, Care Oregon managed the behavioral health Medicaid benefits for HealthShare, which includes funding critical services within our behavioral health division. Even with the funding reduction that we received this year, the CCO still continue to fund critical services at our crisis continuum and care coordination services. For example, they fund our Fidelity wraparound services with children and families. That program focuses on keeping children at home and schools and connected to their community by pairing them with wraparound coordinators and a family support partner. They fund the Multnomah County Intensive Transition Team, also called MIT, who helps adults transition from mental health hospitalization back into the community, offering short-term intensive care coordination in our community. Behavioral Health Call Center. They provide free, confidential services provided by trained clinicians for support, crisis interventions, and referral to mental health and substance use services. Next slide. So you have seen this slide as well before, but today I want to discuss the FY27 budget implication for these services. Our current financial assistance agreement with the Oregon Health Authority went into effect January of this year, significantly restructuring how we fund and prioritize our services. Under the new CFA guidelines, we are mandated to allocate funds across 3 distinct categories, beginning with the priority population. Required services for the priority population must be funded first, and it included programs such as Civil Commitment, Aid and Assist, and PSRB. We can only use state funding for these mandated services. Once the priority programs were funded, we then allocated funds to our core services such as mobile crisis response, the Early Assessment and Supported Alliance, also known as ESA, forensic diversion, adult protective services, and the infrastructure necessary for regulatory compliance. After those 2 service categories were fulfilled, any remaining funds was then directed towards allowable services, supporting initiatives like the Crisis Call Center, urgent walk-in clinics, older adult behavioral health services, and school-based or early childhood mental health was either reduced or not funded. And we'll talk about that more later. Next slide. As you know, the state funding remains insufficient to address the behavioral health needs in Multnomah County. The shift to the prioritization did result in reductions and complete elimination of funding for prevention services and some crisis intervention programs, culture, civic, and youth-focused initiatives previously covered by the agreement. Some examples are the school-based mental health program, the early childhood mental health services, family involvement team, family and youth addiction treatment continuum programs were eliminated. And crisis call center and portions of the adult addiction continuum was reduced. To adapt this year, we reallocated county general fund resources to support programs previously sustained by the CFA. We transitioned other programs, including priority population services, from county general funds to support vital core services and other allowable services. We would discuss this later in more detail as well. Next slide. This budget invests in a wide array of services across 4 critical areas as demonstrated by this slide. These numbers give you an idea of the scope of the services delivered by your investments. The Behavioral Health Division serves 3,000 uninsured or underinsured individuals annually with substance use disorder by providing treatment, recovery support, and prevention services. We provide person-centered crisis services, including a crisis line, urgent walk-in center, and mobile crisis response, and diverted thousands of individuals from emergency resources and law enforcement. The 24/7 Multnomah County Call Center anticipates 85,000 calls in FY27 for crisis interventions and behavioral health support, and the urgent walk-in clinic is projected to serve over 3,800 unique individuals. Our direct clinical services support youth and their families in a wide array of programs such as the school-based mental health, early childhood, and ESA programs. The school-based mental health program is expected to provide prevention services to 3,000 children in FY27. ESA serves over 300 young people with early psychosis symptoms. Its supportive employment program assists 100 youth with job attainment and retention to aid recovery. Our next one is our behavioral health resource shelter and bridge housing supports over 130 vulnerable individuals quarterly with behavioral health issues and to end homelessness. The program also reserved beds for first responders and outreach. And now I'll turn it over to Jessica.
Thanks, Anthony. Good afternoon. My name is Jessica Jacobson. I use she, her pronouns, and I'm in an interim role as a deputy director with our Behavioral Health Division. The Behavioral Health Division navigated a variety of challenges and opportunities in this budget process. Some of these are outlined on this slide. A review of prior year spending showed an underspending on the total allocation for county general funded contracts. The department chose to reallocate some of the funding to other key needs without eliminating services. This was done to ensure that the department is making effective use of the general fund to meet the needs of all programs. The health department is working with the CFO's office to assess contract spending and to use data more effectively to make funding decisions for contracts across all programs. This will help us more accurately predict and budget for contractual spending. We looked for opportunities to consolidate leadership and administrative staff in our division. One example of this was the elimination of a manager position in the care coordination program. This was in recognition of, oh yeah, top tip.
Put it up.
There we go. This was in recognition of a reduced number of teams, contracts, and staff in this program area in the next fiscal year. This helped us to retain client-facing positions and funding for contracted services, and it retains the right amount of infrastructure and leadership support for this program. Next slide, please. Key performance indicators, or KPIs, help us to measure, track, and analyze our progress towards achieving critical strategic and operational goals. We are highlighting one of our KPIs here that focuses on how we help community members to access the right care at the right time through our behavioral health call center. As we shared earlier on how this budget delivers, our behavioral health crisis call center typically supports more than 85,000 calls per year. We have a Spanish language line where callers can speak to a fluent Spanish-speaking mental health consultant, and we take calls from those seeking crisis support in Clackamas and Washington counties as well. We do receive funding from both Clackamas and Washington counties to support this work. We are very proud of this program, which was awarded accreditation from the American Association of Suicidology in 2025. One of the key priorities of the work the call center does is to prevent people in crisis from overwhelming hospital emergency rooms and emergency services accessed through things like 911. This KPI reflects our commitment to connect callers with the right resource to meet their need at the moment and to minimize unnecessary referrals to emergency services. This results in better outcomes for callers and helps to ensure emergency services are available when and where they are most needed. We anticipate a minimum of 81% of the more than 85,000 calls triaged by our call center staff will be handled without the need for referral to emergency services or law enforcement. Next slide, please. The graphs here compare the behavioral health operating budget and FTE from fiscal year 26 to fiscal year 27. Overall, the operating budget decreased from about $155 million to $128 million, representing a 17.1% reduction. Similarly, FTE decreased from 332 in FY26 to 291 in FY27, a 12.4% reduction. These changes are further illustrated in the breakdown by funding sources below the graphs. Some high-level takeaways are that the Behavioral Health Division will not have any preschool for all funding in FY27. The supported housing services funding was reduced. Some of that funding reduction represents one-time only funds that were paid for capital investments and were not intended as ongoing. So that was an accomplishment, not a loss. The Health Share Care Oregon reductions represent a significant change. The majority of the impact to our FTE from those reductions were already realized at the end of the calendar year 2025. Next slide. As you saw yesterday, the entire department is impacted by stacked reductions. You're also aware that the Behavioral Health Division was particularly impacted both earlier this fiscal year and in our FY27 funding with stacked reductions. This includes CFA changes, CCO investment changes, and SHS reductions. This landscape is complicated by increasing community needs and the anticipation of increased needs as some of the federal policy impacts are realized over the next year and beyond. Next slide, please. Pass back to Anthony.
In the development of the budget, we worked hard to maximize efficiencies where we could. For example, we made the decision to cut a contract outreach services and behavioral health administration that recognizes there were similar services being offered by the BHRC outreach van. We analyzed funding levels across all of addiction and mental health contracts to better align with our service utilization rates. We reduced administrative and management support when possible to prioritize direct services with clients. In care coordination, for example, this included an elimination of a manager position, which allowed us to retain client-facing services. Next slide. Before we talk about the reductions, I want to acknowledge the difficulties of these decisions. None of these decisions were easy. For many years, we made significant investments in centering the needs of culture-specific communities. We have not lost that focus as we face funding constraints across multiple fiscal years. Some of these reductions will undoubtedly have an impact on our equity work. These impacts are weighted carefully and are results of focus on services that fulfill our unique statutory roles. And still, it is difficult. I also want to acknowledge the impact to our employees serving the culture-specific communities that are affected by the reductions. We have taken a concerted effort to hire staff reflective of communities that we serve, and the change to funding streams have disproportionately impacted Black and African American communities. Jessica and I will now begin sharing with you some lists of our reductions. In the Behavioral Health Administration, we reduced a $393,000 contract that eliminated 2 peer contracts that provided outreach and support for individuals experiencing behavioral health challenges. An estimate of 330 individuals will lose outreach and peer support. As I stated earlier, some of the impacts will be mitigated by the BHRC outreach van. Additionally, we will work to coordinate and collaborate with our Behavioral Health Resource Network, also called the BURNS partners, to address the gaps in the funding impact. We work diligently with our BURN partners who provide culture-specific outreach and creating outreach and peer-delivered services to these impacted individuals. Furthermore, we plan to work with other peer organizations in assisting us with additional outreach and engagement efforts. Again, as I stated in my opening, many years we have focused our funding on the needs of cultural civic communities and having voices and efforts of those communities. In the Behavioral Health Division Administration Office, Program Office, we reduced a 1.0 FTE in our consumer engagement team. This fiscal year, budget challenges necessitated a staffing reduction to meet our CMHP statutory requirements and balance our equity efforts with those requirements. Our leadership team remains committed to supporting our work with the African American community and with the work with OCE to find alternative ways to maintain this effort. Our quality management reduction. In our medical records area, we had a reduction of $60,000. That was for a temporary position, and that has no impact because that work would be absorbed throughout our division support staff. Our behavioral health quality management, we eliminated a 1.8 FTE due to care organ funding reduction. Impacts would be mitigated by the fact that some programs have shifted to the EPIC system and other program reductions have resulted in a lower workload for this team. Our coordinated diversion and commitment services, this PO reduced this program offers reduced 5 mental health clinical services specialists from the mental health court. These FT has been reassigned to support our CFA mandated aid and assist for forensic diversion. This reduction would limit BHD capacity to care coordinate and court monitor for the 80 to 90 mental health court participants at any given time. However, the impact is expected to be mitigated by the court and interdisciplinary team model and a $377,000 criminal justice commission grant that would fund peer support services for our court participants. In our addiction and prevention continuum, we have under the adult, what's that?
Next slide.
Oh, next slide, I'm sorry. In our adult addiction treatment continuum, we had a reduction of $150,000 that was made to contractual services for cultural civic outreach services. This cut specifically target pre-engagement efforts to cultural civic youth services with the goal of getting youth into treatment. In FY26, there were 82 youth that received this service. And in the first 6 months of this fiscal year, there were 36, with 11 being connected to their treatment services. The impact would be a loss to the agency's ability to engage African American and immigrant youth. These services was previously funded through our CFA funding contract. And we will work to mitigate that through other peer organizations to try to find a way to mitigate those 86 or 72 individuals that they would be served. In our addiction services, gambling treatment and prevention, this was a reduction of internal staff, FTE, from 1.0 to a 0.80. This was due to a reduction in our state lottery funding revenue. This program anticipates minimal impact as they have implemented new efficiencies to mitigate disruption to outreach and engagement strategies for individuals experiencing problem gambling. In our addiction detox and post-detox housing, this was contractual services that had been reduced by $60,000, resulting in the removal of one of our 2 care coordinators that served the uninsured that was receiving detox services. This role supported individuals transitioning back into the community after they finished a withdrawal management program. While the majority of the participants in these services currently have Medicaid, the department is still monitoring the potential impacts of H.R. 1 on the uninsured population to evaluate future investment needs to this program. The family and youth addiction treatment continuum. This removes CFA and County General Fund, resulting in elimination of this program. These were contractor services specifically dedicated to youth outreach and early intervention program. This particular services was specific to one provider that provided intervention services in the East County area. This was reduced, this contract was ended because of internal communication that the agency had, that they missed the RFP or request for proposal qualification deadlines to contract with Multnomah County. These services would be absorbed within our prevention team. There should be minimal impact because the utilization was low prior to this. Next is our family involvement team. Reduction in CFA and County General Fund eliminates this program offer. It discontinues the four contracts with 5 different community-based providers that support men and women who have lost custody of their children. This reduction will impact approximately 262 individuals, 36 males and 164 women that was receiving services in our 4 residential and 1 outpatient program. The existing infrastructure of the DHS and the service provider that works with this population will absorb or could absorb the case management services. Case management is often a function of residential services, generally to provide care coordination to aftercare services, advocacy and support for mothers in their legal system, or child protective services. This reduction is a realignment to focus resources on services that falls within our statutory obligation while transferring the responsibility for these specific services back to the State Department of Human Services. Promoting access to HOPE, care coordination, eliminates 2 FTE and other additional expenses. This reduction was a result of a decrease in SHS funding. The remaining PATH coordinators would absorb some of the efforts supported the unhoused individual with sub needs. Now Jessica.
Yes. The Behavioral Health Division's Safety Net Services program includes several programs that provide some of our core safety net services. I want to acknowledge that this program area's name can be confusing since all of the Behavioral Health Division's program areas include safety net services. The Safety Net Services program includes crisis services, residential services for adults with serious mental illness, adult protective services for adults engaged in behavioral health services in Multnomah County, the Older Adult Behavioral Health Initiative Program, the Behavioral Health Resource Center, and contracts with mental health providers and culturally specific mental health providers to serve individuals who are uninsured or underinsured in our community. The Behavioral Health Crisis Services Program offer has 2 significant reductions in FY27. The Behavioral Health Shelter Outreach Team provides consultation and on-site outreach to address and resolve crisis situations that do not require mobile crisis response from Project Respond, but are disruptive to the shelter environment and likely to result in poor outcomes for the participant. This team also provides follow-up support post-outreach. This funding reduction will result in the team serving fewer locations by about half, from 16 to 8, and likely a reduction in days or hours that the service is available. The second significant impact in this program offer is the elimination of contracts for 2 specialty crisis lines serving youth and veterans. While these specialized lines provide important services to specific populations, these populations can be served by 988 and the Multnomah County Crisis Line. The program offer for the Mental Health Crisis Assessment and Treatment Center, often referred to as CAT-C, will be eliminated. This program was funded with beginning working capital, and the reduction results in the loss of 1 bed at CAT-C. While this resource has been underutilized, it is a reduction in options for uninsured and underinsured individuals. CAT-C will continue to operate at full capacity with Medicaid payers. The Mental Health Residential Services Program offer was impacted by changes in the CFA expectations related to serving older adults. This resulted in the elimination of 2 FTE from the Older Adult Behavioral Health Initiative, or the OABHI. This will reduce our capacity to offer consultation and training for community partners and internal teams working with older adults. The culturally specific mental health services program offer and the culturally specific mobile outreach program offer were both impacted by reductions, and this will result in the elimination of a contract that provides 14 culturally specific transitional housing beds for Black and African American men with justice system involvement. This housing program serves approximately 45 individuals annually. The Behavioral Health Division will work with the provider on a transition plan to assist in identifying housing resources for participants currently housed in this program. Support will include consultations and more individualized support from care coordination or other teams in the Behavioral Health Division as needed. In the deflection and sobering program offer, there was a reduction to funding for security services at the Pathway Center. The Behavioral Health Resource Center has a reduction to security that the program has anticipated, and this is not anticipated to cause any negative impact at service levels. Next slide, please. The Care Coordination Program area is composed of 3 care coordination programs and contracts for shelter, housing, and services. Wraparound is a team-based model that is family-driven and youth-guided. It works by building on family strengths, collaborating with community resources, and incorporating shared decision-making. Each approach is individualized and informed by the family's culture. The Multnomah Intensive Transition Team is a flexible, low-barrier, collaborative, intensive short-term transitional support intervention to ensure clients get connected to services following discharge from a mental health hospitalization. Choice connects adults who have complex behavioral health needs with mental health services so they can live in their community and avoid restrictive care. The Care Coordination Team manages a portfolio of contracts providing behavioral health shelter, permanent housing, outpatient services, and peer supports to serve individuals with complex behavioral health needs. The Choice Model Program offer is impacted by the loss of Care Oregon funds in mid-fiscal year 26 and by the shift from having a standalone intergovernmental agreement with the Oregon Health Authority to now being included in the county financial agreement in FY27. The changes retain current service levels for the majority of programming and all client-facing FTE. Changes to the Multnomah County Care Coordination Program offer between FY26 and 27 were mostly discussed mid-year when the delegation agreement with Care Oregon ended. This did result in the end of 3 programs, the Youth and Adult Intensive Care Coordination Teams and the Jail Care Coordination Team, and the reduction of over 20 FTE. These teams provided intensive care coordination to the Care Oregon members with complex behavioral health needs. In the FY27 planning process, the Care Coordination Program proposed redirecting funds currently used for peer services to crisis services. This will result in the full reduction of contracts with 3 providers and impacts peer brokerage services and training programs. Care Coordination leadership is working with the peer brokerage vendor to identify resources to ensure that client assistance commitments are fulfilled, which also includes rent assistance. A reduction in supported housing services funds in the Shelter, Housing, and Supports Program offer will result in the closure of 1 behavioral health motel shelter program. Funding retains 1 behavioral health motel shelter program and permanent supported housing in both site-based and scattered site settings for over 200 individuals with serious mental illness and co-occurring substance use, and permanent supported housing for individuals in recovery. Next slide, please. The Behavioral Health Division Direct Clinical Services Program operates several distinct yet complementary programs that provide a combination of prevention and clinical treatment services for children and families in Multnomah County. Services are consistently designed to be low barrier, and the program has emphasized designating the majority of positions to have knowledge, skills, and abilities to meet the needs of underserved populations in our community. The new FY27 Gun Violence Response Program offer is part of the Community-Based Mental Health Services for Youth and Families program offer in fiscal year 26. The programs represented in this program offer primarily support violence prevention and response. In the department's requested budget, a combination of the loss of beginning working capital and county general fund would have resulted in the elimination of the gun violence program, estimated to serve approximately 150 families in this fiscal year. This reduction would have impacted 5 FTE and 2 contracts with community partners. The Behavioral Health Division is grateful that the chair's budget restores funding for 3 FTE, which will retain services for at least 75 families annually. A county general fund reduction resulted in ending our provision of 1.9 FTE for the Child Abuse and Response Evaluation Services Organization, CARES Northwest. Although this service will continue through the community provider, this reduction will likely result in longer wait times and fewer culturally specific clinicians. Finally, the county general fund reduction results in the reduction of 1 FTE capacity to provide culturally specific LGBTQI2S+ clinical review and consultation for direct clinical services programs. In the school-based mental health services program offer, CFA funds were removed based upon the changes to the agreement. There's a corresponding increase in county general fund. A revenue assessment from the fiscal year 26 data and the implementation of a new electronic health record resulted in a reduction and elimination of 2.84 FTE of school-based mental health clinicians, impacting 4 positions. This would have resulted in lower service levels across various school locations. The Behavioral Health Division is excited and grateful that the chair's proposed budget restored these positions with ongoing county general fund. The reduction of 1 FTE billing specialist that was funded with our beginning working capital will limit billing support for this program in fiscal year 27. The Early Childhood Mental Health Program, with the new CFA priorities, necessitated reallocations and loss of all CFA funds for this program. This program offer also reflects a reduction of county general fund. The reduction of summer hours retains more coverage during the school year when most programs are operating. These staff currently provide technical assistance and program planning for Head Start in the summer months. A reduction in treatment services will result in less access to community-based services. There's a funding reduction here that also results in fully cutting a contract for complementary services. The service provider will continue with a lower service level. Next slide, please. Moving on to some new investments. The first 2 program offers on this slide were mentioned earlier. The Gun Violence Behavioral Health Response Team was partially backfilled with ongoing county general fund. This program will retain 3 FTE and will continue to serve at least 75 families next fiscal year. The school-based mental health services received ongoing county general fund backfill, which will retain the same service level and client-facing FTE in fiscal year 27. And then a new specialized street-based outreach services program offer that's funded with one-time only county general fund in the chair's proposed budget. This program will help to address the urgent intersection of behavioral health needs and unsheltered homelessness in and around the Central Library and surrounding neighborhoods. This investment will pay for 2 full-time outreach professionals. The service provider will significantly scale direct engagement, treatment connection, and system navigation for individuals experiencing homelessness and substance use disorders. This will result in 200 enrollments into community-based outreach programs and 120 connections to treatment services. And I think that wraps up our formal slides.
Thank you. Opening up for questions. There's a lot of information here. So,
Yeah. Yes, I'll start just on slide, thank you for just the update, just different seeing the numbers as far as the impacts from CFA and just overall impact. So I know it's a slog. Just on slide 12, I just have a question about the preschool for all. The $2 million that we had set aside for that in 2026, what was that used for as far as like the programming? What did that fund? And then why didn't we carry it over to this year?
I think this, yeah, it would be the graphs. So the Behavioral Health Division Preschool for All program offers a variety of consultation as well as treatment intervention. And those services are not intended to disappear, but are being utilized to pursue a slightly different model. And that's something that we would defer to DCHS to talk more about their plans for that.
They're here, and I know they plan on talking about it in their presentation, but I didn't know if you want them to talk about it now.
Yeah, just briefly.
Okay.
This is great because I had the same question, so just, I had written. I'm going to wait till DCHS shows up.
Thank you for being, I know, thank you for being here, Rachel. She's smart. She just sits in this room and just waits.
I don't know if that's smart, but here I am. Rachel Pearl, she, her pronouns, interim director for Department of County Human Services. So it's a variety of reasons why Preschool for All is making this change. A couple different reasons is underutilization, feedback from providers that we need a different service model, and conversations with behavioral health. That's not the model that they provide, particularly the model that supports individual children who have higher needs from a behavioral health experience. So a lot of the duplication of services that were provided are provided by the Preschool for All coaches in that existing structure for the program. And it's a little bit of a different model that's needed. And so that is where the transition is coming from, and based on a lot of feedback from providers.
Providers being the owner or the
Preschool,
operator?
preschool providers.
Got it.
For the, this is the same program, but I'm going to you about it. Are those services Medicaid billable for those who are on Medicaid?
Some, a small subset. The treatment intervention services with families are Medicaid billable. And I would absolutely defer to you if there's other ones that I'm not familiar with that are, but that's the primary. And it generally does take some time to get folks formally enrolled in services, and that's a small subset of the services that were being provided.
Okay.
So just see if I make sure I understand the differences in the models between what the health department provides and what DCHS says it needs. The focus of the health department model is more like the adults and families, and what DCHS says it needs is more of a child focus.
Yeah, thanks, Commissioner. So the model that behavioral health was using, which is something that they use in other settings, I believe, as well, is a whole classroom support. And what the program needs from a mental health, behavioral health support perspective is child-focused.
So like a specific child versus these are like a broader classroom support.
Yes.
I'll definitely have more follow-up questions, but I'll just do that here. I'll wait for the DCHS meeting to learn more.
Thanks, Rachel.
Did you have more questions?
I
or
do,
should-
but I
we can
got to get organized. We
go
can
back
have
and,
to, yeah.
back and forth. I'm just an overarching statement. Given the challenges in our community, it's disheartening to see in every category. This has nothing to do with you. You're just sitting here, that's why I'm looking at you. I know it's not your fault, but like, so disheartening to see in every category of funding reductions. There's no bright spot anywhere, especially when the need is so great. So just a comment, so really hard choices. I did have a question about, on slide 19, the gun violence response program. I know in parts of Multnomah County, the level of gun violence has reduced from very historic highs. I think in 2022 and 23, we were at record levels of gun violence in parts of the county. And I'm wondering if you can speak to what you're seeing more broadly across the county, and your thoughts about, making a reduction. I know no reductions are easy, but making that reduction what impact we're going to, you think we'll see on gun violence. I would hate to see it go back up to the record levels that we had in 2022 and 2023.
It might be helpful to share just the service that they provide as well for the families.
Okay, so, sorry, just to interrupt. Can people move their mics closer to them when they talk? We have a hard time hearing. I know. I think that's,
I'll project.
okay.
Use my radio voice. Okay, sorry. I was just saying, it might be helpful to share just the level of care, what they actually do with families and the services that they provide in general when an incident happens. I think that would be helpful too, as far as context.
One thing I'd like to follow up with you about, Commissioner, is just the levels of gun violence across the communities. We can get some data on that. I mean, you all can speak to what you're seeing from the program perspective, but I'd like to get you an epi data answer to that question. As a follow-up.
I would just say we'd probably move this up closer. I think we would check in with the gun violence team to maybe get a better perspective of what you're asking. I just know gun violence and, we're a behavioral health, so a lot of the services we're going to be providing is going to be really not some maybe prevention work, but the city does a lot with gun violence. So I think it's a combination of things that probably is impacting the reduction in certain areas, but we can speak to what we do as part of that whole process, and we can bring you back that information.
Can we also find out, my understanding is these are actually CMHPs who do this work. Is that correct? QMHP. They're a QMHP. Sorry, QMHP.
We're also the CMHP.
Globally, we're the CMHP. Individually, they are QMHPs. Acronym fun. Are they billing? Could they bill? How much of their services are billable? What would be the unfunded general fund? That is a blanket question for every reduction. Could you bill? Do you bill? At full billing, what could you bill? What would be the unmet general fund still?
Sorry, I can say, yes, they can bill, yes, they do bill, and the detail stuff, I would want to follow up with more detail.
Can I ask about the reductions to the PATH care coordination for 0101? I see a reduction of 2.15 FTE. How many would be remaining?
I think it was a total of 9, so 8. I think we have 8 left.
8 left.
Yeah.
And what do they do?
What they do is they go out, so some are specialized in different areas. We have one that's focused on the criminal justice population. What they do is go out and engage individuals, and they do clinical screenings, and they get people into services. So the focus is like we have some that focus on the LGBTQ community through a Ryan White grant, and they focus on getting people in housing. And once they get people into services, they follow them once they get out, and they navigate them through a clinical, because they have clinical connections as well as clinical skills to know what the next best services for those individuals are.
And these are county employees?
These are county employees, correct.
Where are they located?
They are located in the field, or like you mean, their home office is downtown.
Is downtown?
Yeah.
Okay. How do clients find them?
So we have a referral. Some of it is word of mouth, some of it is agency. Now, they used to be called the ABC team as part of when we was managing the health plan. So they have been known in the community, so we have a community referrals that it comes through. You saying how would a client know? Or is that?
Yeah, how would somebody end up being connected there?
So they can come from multiple places, the Housing Services Division, DCJ, community referrals. Most of our referrals come from community referrals. It comes from the community. people know what they do, and they trying to get people into treatment, trying to get people into services, and they navigate them pretty quickly. Deflection as well.
So are people referred from deflection to them?
Yes, correct, yeah.
Do you know what their current caseloads are?
I'll have to get back to you. Yeah.
Okay, that'd be great.
Okay.
The security cuts to the deflection center, is that just going to be just a reduction in the amount because that's just an assessment of need, or is it, how will that be actualized?
Understanding what you just said is correct.
Yeah, okay. Can I find out what the overall reduction in funding we receive for behavioral health services from the CCOs has been in fiscal year 2026? Do you know that global number? Okay. And again, this might not be something we know, or it has not fully hit us yet. Are we seeing an uptick in our crisis services due to reductions in the CCO-related services? I know they significantly limited their access through reducing number of providers, their cuts here. I'm just curious if we're seeing an uptick on our kind of safety net crisis-based services.
Our amazing safety net senior manager has chatted me that not yet.
Okay.
But we're definitely kind of monitoring and watching that. But we really couldn't say that for sure.
I think we have that path, Kate. It's between 12 and 15.
12 and 15?
Mm-hmm.
Okay. I want to go back to the CFA slide. Can you explain how this CFA agreement changed what we're funding or prioritizing from previous? Yeah, thank you. It's slide 7. From how we use CFA funds or could use CFA funds previously?
I'm going to take a stab, and then you please. I think the difference with what they did this year was that once the old CFA really called out very specific funding for core services. Like it said you had this amount of money to spend on certain services. They were like service elements, and it says you had this much for crisis services, you had this much for addiction treatments, or you had a set amount, so you could budget every year based upon those services, and funds were dedicated to those services. What they did with this model was they bucketed the funds, and they left it to the county by mandating a structure. If you look, and I had the agreement because I knew somebody would probably ask, it lays,
Page 75.
yeah, it lays out in a very structured way what you fund first and what you fund next. And then the funds would be allocated based upon this sort of outline. Once you fund this, then you do this. And what we had to do, because of Multnomah County and a lot of people from other counties coming, what we did was allocated the funds based on what we did the year before and moved off the priority population because we had general fund that was associated, and then sort of moved them into this order that they gave us. And then we sort of try to really looked at what was going to be the greatest impact in our community to prevent preventable deaths, people going to the hospital. And as you know, we operate from a crisis a crisis perspective. A lot of the services that you really need to prevent crisis is usually the last things that they fund. So then what happens is that you see outreach services, prevention services being the lower thing, and then all the most expensive things being at the top. So that's what we was faced with, is sort of, hopefully that helped, but that's how they laid it out. More of the expensive things was paid for first.
Has the state ever provided a level of funding through CFA that would fully fund their various buckets of service we should be providing?
I think the county would say no, because we bring a lot of county general funds to support the people, and if we didn't have that, our community would be in a worse condition than they are there. So the answer for at least Multnomah County will be no.
One of the things that I think the public might not be aware of, because we get feedback all the time. County, you're the local mental health authority. People can't get timely access to a variety of different treatment settings. Certainly drug and alcohol treatment, there have historically and are still, waits to get into the right level of care for people. I think there's been a lot of conversation about, why aren't you doing more for XYZ? And I do think the public should be aware that we didn't set these priorities. They were set by the state of Oregon. I'm not really sure no, I do know for sure. If I were prioritizing, I sure as heck wouldn't put as my number 1 and 2 priorities the prosecution of people with mental illness. That is not treatment. It does not meet standard of care. That is not what aid and assist, or to some regards, post-state hospital PSRB services are. I'm not saying they are not services that are important, but I really, when I think local mental health authority, I don't think facilitating prosecution or punishment is a mental health service. But that was not our choice, and I think it's really important for the public to understand that that was not this board's decision. I would absolutely like to be funding a whole lot more of the core and allowable services, and I think I'd love to not be in the business of doing some of the things on this list. But I think my question, as we continue to get less and less from the state to do these core or upstream services, and we have a CCO that has contracted their behavioral health system, I am very, very concerned about what that means for our community, and that we were already, I believe, 48th in the nation for Oregon, not Multnomah County, Oregon as a whole, in the quality of our local behavioral health system. I think the decisions that we're now living with jeopardize that ranking. And it's just, wow, when Mississippi beats you, that's wildly concerning to me. But I don't know how much longer we can do some of these things. And these are things that the public are constantly saying, these are the ones we want our community to do. And we do put general fund in it. I actually would say, as a county, we do more general fund services than any other county. Some of that's size, but some of that is how much we prioritize these services. But it is breaking. And if we are the crisis system and we can't even put sufficient resources into the crisis system, because we are now given our prioritized lists and prosecuting people with mental illness is more important than treating people so tragedies never happen. I don't know how to tell the public, we are trying so desperately to address some of these issues, and our hands keep getting tied behind our back and weighted down, and we are running out of creative options to try to fill these holes. And I think that some of these choices are going to result in an increased need, and I think our news wants to find, if we only would have given somebody a magic pill. That's not real. I find those conversations profoundly offensive. If we just would have civilly committed more people. That is a crisis intervention. It doesn't prevent. It's for when people have already reached crisis, and you don't always catch it in time. If we want to prevent tragic things from happening, we have to have access to these core and upstream services. That's how you prevent people from ever getting so ill that we need to do these priority things. Sorry, I know I'm preaching to the choir, but the number of people who talk to me about this issue and the deeply unsatisfactory answers I have to give, I appreciate the presentation. I think it's helpful for people to get that, we didn't make these choices, and we are now trying our best to mitigate the damage of other people's prioritization.
Thank you, Commissioner. Other questions?
I have questions.
Okay, go ahead, Commissioner Singleton.
Thank you all. This has been really helpful, and echo, I think, as I often do, Commissioner Moyer's comments about the state and how the funding is restricting us to what we can do. And I know that none of these cuts are good cuts or things that y'all wanted to do. Just wanted to follow up on a question I had yesterday, and this can come as follow up on where else. You mentioned the Central Library outreach, and I'm curious where else you're doing geographic specific outreach in any of your programs.
We get into that. Oh, you can do it.
Okay.
I got the wrong glasses for computers.
It's little.
It's little.
All right. So there's a few teams. The majority of geographic specific outreach is happening in the downtown area, but different parts of the downtown area. So there's some outreach that's occurring related to the BHRC. That's I'm trying to think of the right Old Town area. Then also, I think
Jefferson, tomorrow up by Jefferson. Tomorrow up by Jefferson. They doing some outreach up there.
see, this is a group answer.
Yeah, what is it? I can't think of the name of that.
But it is throughout the downtown core area that outreach is occurring for that. Then we also are working with another agency that's also doing outreach in the downtown core area, but not specifically related to BHRC work. And then I think some of the other teams on this list are not actually funded by BHD, so I'm hesitant to try to line them out. But then I did want to double check, Anthony, is there outreach occurring related to the deflection center that's geographic based, or is that everywhere?
No geographic place, but I think it's Goose Hollow is what I was thinking of. Goose Hollow.
Okay.
No, it's really focused on just wherever the police are making the deflection. So it could be any place in the city. And then,
Thank you. Sorry, go ahead.
there is some outreach. I'm wrong about that. Gresham, we have some outreach being done, and Gresham is a pilot project outreach into people that's in deflection out in Gresham.
Thank you. My other question is on program offer 40099. In the program offer, it shows a reduction of 184,000 plus change. But on page 8 of your budget, it shows sorry, bear with me.
Commissioner, can you repeat the number?
Of the program offer, it's not a slide number.
Yeah, no, the program offer number.
Yes, but I already moved that page, so hang on one sec. It's 40099, Early Childhood Mental Health Program. So in the program offer, it's a reduction of a little over 184,000 and a decrease of 1.19 FTE. But in the front part of your budget, in the budget book, it shows a reduction of 469,000 and 2 FTE. So I'm trying to understand which is accurate so that we know how many FTE we're losing there and the impact of that.
Could we get back to you on that?
Absolutely.
Okay.
Thank you. That's it for me.
I was just trying to find this in here, but maybe it's just easier for me to ask. Where are the youth line program reductions? I understand there's a substantial reduction in that, and I'm curious which program offer it's in, and that's a service in which youth peers counsel other youth who have called for a variety of mental health issues. And I'm curious about the zeroing out of that and what sort of how those services are going to be provided, or are they just not going to be provided?
So I think the program offer that's in is our crisis services, the 40069. And in terms of that reduction, it really comes, it's not something that we wanted to reduce or feel like it can be perfectly covered by another service. It's a really excellent specialized resource for young folks. And it is not part of our statutory requirements. It's something that we have historically used state funding in addition to some general fund to fund both the youth and the veteran lines. And as we were really looking at like significant constraints across our system and needing to figure out what we could retain and what we couldn't, this was something that because there is substantial funding that does come from the state for 988, that is not the service, like we are not the service provider of 988. We actually aren't using any state funding for FY27 to fund our call center. We're using other funding sources. And so continuing to fund these two lines that are really specialized just didn't make sense to us given the difficult decisions that we had to make. But it doesn't change the fact that it's a really valuable service.
So this is just based on my experience as a school board member. I know that there was just some substantial, just getting the whole infrastructure set up and getting all the peers, the youth peers trained. That's all just going to go away.
I would say I probably have to follow up to find out if we are the sole funding source for that.
Okay.
Yeah.
Thanks. That's an acceptable answer.
I have a follow-up question on that, though. Is those lines, veterans and the youth line, are statewide available lines? Is that correct?
Okay, that I don't know, but I do now know that we covered about 8% of the total budget, so it is not just zeroing out. It's a reduction, not a total elimination of their budget. And yes, it is statewide.
Thank you.
So another question I had relates to Project Respond. That's in this division's budget, right? What's the program offer of that?
It is the same program offer, 40069, the crisis
Oh, okay.
services.
It's all wrapped in together. So this is our sort of non-law enforcement response, right? And so I'm looking at it right now. It had an $18 million, the whole program offer $18 million in 2026, and it's down to 16, so about a $2 million reduction. What portion of this is Project Respond?
What portion of the entire program offer funds Project Respond?
The
Sorry,
entire program.
double-checking.
So we're reducing Project Respond by 2 million?
So we would need to get back to you on that, because this program offer, as many of our program offers do, has a number of items that are included in it. In the
Smushed
crisis,
together?
it's the walk-in clinic, the call center, Project Respond. There's a great deal of things that are in this program offer.
Yeah. This is something, and since we're not close to voting on the budget, but I very much would like to better understand the programmatic impacts, because I think the very nature of it, it's Project Respond, and so I want to make sure that we have the resources that actually, when somebody calls and need it, that there is a response. So again, I don't need it right now, but I would love to understand more, kind of disaggregate some of the programmatic piece, and really with a really very specific focus on that piece, is what I hear from a lot of people is, Portland Street Response has one role, but Project Respond, so that's the city of Portland, but Project Respond has a very specific, separate and distinct role, and that it's for people in much more acute situations. And even now, I've heard is sometimes the response is uneven, so I just want to understand what, how much of that 2 million cut would be Project Respond and what impacts that has for service. And again, with I'm really trying to focus on a non-law enforcement response, because we know if Project Respond doesn't respond, then likely the police are going to respond, which we know is not the response probably that's most appropriate.
And we can definitely, if there's additional questions, we can follow up, but I apologize, I was getting muddled at the beginning. Both the Project Respond funding is essentially stable from this year to next with continuing service levels. But it sounds like there might be some additional questions for us around.
Yeah, if that's the case, that's good to know. But also, I guess, because I'm looking at the performance metrics, and one of them is just the number of overall, let's see, no, that's the wrong one. Maybe I'd like a little bit deeper dive on the performance metric we have here, and just how closely we're meeting it. Again, I'm asking the questions because I really value the service, and I know that there will be an alternative response, which is usually a law enforcement response, and just want to understand if it's the same level of funding. Is it the level of funding that we need to have a response to, instead of relying on a law enforcement response?
If I could piggyback on that question, has Project Respond's model changed? Because they do come with law enforcement, and usually law enforcement does the transport. And I know it's not the same as the police responding, but it's also been a challenge of the model for folks who are not willing to engage with law enforcement as part of that mental health crisis response. Is that still the case?
I'm a little bit relying on somebody that's sending me details, but law enforcement is not responding 100% of the time with Project Respond. It depends, and I think that the transport we try to utilize other transport, not law enforcement, whenever possible, so that has shifted a little bit, and that's been a while, but yeah.
Yeah, that was my understanding. Again, I don't need the answers right here, but I just want to better understand that and make sure that, because I know that's a critical sort of part of the ecosystem of responding to people in crisis that the county has responsibility for.
Yeah, I want everyone to get their questions answered that they have regarding the budget ahead of time, but one thing we might want to think about is inviting, post-budget, having a briefing on the crisis response systems, not just the counties, but the cities and other partners, so that we can see what holistically has happened, because that is one thing that I continually believe, like, we need to have better alignment in that system, and I would really welcome the chance for the board to have that conversation.
I would love that. And I would also, would be remiss if there's some sort of budgetary impact to not be raising it now during the budget process.
Yeah, that's why I said, like, started off with
Speaking
saying
of
that.
budgets, has the state of Oregon addressed their Medicaid billing issue that has made it largely impossible to bill for Oregon Project Respond? I know that there had been conversations, 2 years ago. I think we were in a similar work group when I had a different job, about that other states had actually been able to align their billing codes where you did not actually have to transport somebody in order to bill for some of these crisis intervention services. But it's a state issue. It's what the state creates a code that allows that or not. Has there been any movement on that? I think it was part of the same conversation as, like, some of the community health workers are peers, and I haven't tracked that conversation in a while.
I feel like we would need to get back to you on whether or not the state has moved the dial on that. However, what I would say is that locally, okay,
Justin's
but let me
favorite
finish what I
topic.
want to say before you jump in. Locally, we are extremely fortunate. Our CCO partners, who are managing the majority of the Medicaid benefit for folks for behavioral health, work with us and with our contracted provider, so that they're able to receive the billing codes as much as they're able to, and then also they provide funding in a way that does fund a significant portion of the crisis system. So.
Can I make one comment just on that, Justin, before you chime in, that I was going to say earlier? I think kind of this is the reason why in our conversations with the CCOs, the counties were really united on that we needed the investments in the crisis services that they gave, and as decisions were happening about the other sort of reductions, this was a huge area of need for a variety of reasons. A, we need it for just response, and B, the more reductions that are happening in other places we know can impact our crisis system. So just kind of, in any future budget conversations as they relate to state funding or CCO funding, this is a connection that I wanted to make as well.
So there's a couple kind of larger state policy questions there around. So state of California opened up some billing codes for street medicine to do this. It's been my understanding, it's been very difficult for them even to implement that. One of the problems you run into is, when you have someone in crisis on the street and you know this, getting billing information and getting their Medicaid number from them is next to impossible. And so there's a lot of difficulty there. And I think that's where we've gone with Care Oregon and others, is having that kind of block funding. I think it is something that, I would say needs to be explored more on, are there some avenues where we can find some, where we can get that information? Because at the end of the day, you can't bill unless you have the person's enrollment information, all that. And just to build on what Rachel was saying, and for us to have the back-end system to be able to do that, we currently are stretched so thin in our kind of back-end admin for doing this work. I mean, it is, I met with the team the other day to talk about some of the Medicaid work I'm doing, and it is amazing that the number of nights and weekends they're working to keep up on, moving from Evolve and Epic and doing all that billing. So, I mean, a really shout out to that team because they were pretty impressive.
Justin. I know that when we first started talking about the ability to bill Medicaid for some of the crisis response work, one of the questions was, that we need some help with at the federal level. It's like the assumption of coverage, right? And how helpful that would be in being able to provide care. So.
Presumptive eligibility.
Yeah, presumptive eligibility, exactly. Commissioner Singleton, did you have any more questions? I wasn't sure I can't remember where we were with folks. Maybe Commissioner Jones-Dixon, any questions?
Yeah, all my questions I got out. Thank you.
Okay, thanks.
Just a final question. Which program offer does the MIT team live under? Or you can just email it to me. I'm just curious. I couldn't find it yet. Pass.
Okay, thank you so much. We really appreciate the time. I'm sure if there's any, I know that there were a few questions that,
I'm sorry.
okay, we have one more question.
And I know like it's the big health department day, so I could ask later, but I figured the behavioral health. There's a lot of, this kind of links back to this morning, but there's a lot of conversation at the community about the county distributing needles or needle exchange. What program offer is it? And the numbers I've heard are like, they're millions of dollars. And when I ask the question, so this is a question mainly to bring into the public light the actual numbers. And so I ask, and the staff provided this number, but in the program offers for the behavioral health division, which program offer has the syringe program? And I can pull it up quickly, but maybe your staff might have it.
Short answer is it's public health, and they're up next.
Is that in public health and not in behavioral health?
Yes, it's in public health.
Great. Well, everybody's ready for the question. And you actually already answered it, but I wanted to be out there because I get a lot of people coming in with here's what the health department is doing, and I want just to make sure that we all have the same baseline of information. So there you go. You've had a preview.
All right. Thank you, Anthony and Jessica, very much and I know we've got folks here from the Behavioral Health Division as well, so thank you all for joining us today for this presentation, and we'll look forward to any of the answers to the follow-up questions when you're able to put them together. All right, now we're going to move on to our second section for our behavioral health, for our health department afternoon, which is going to be the public health division and our health officers. So we appreciate everyone being here for those. Ta-da, come on down. And I love the on-brand t-shirt that you have today. Thank you. Okay. All right, good afternoon and welcome.
Hello. Keep my trusty phone. Okay. All right, it's public health time. Have you had a break? Have you had your water? Stand up, stretch, do those wellness things as we dive into another 90 minutes. Okay, good afternoon. I'm Kirsten Aird. I use she, her pronouns, and I am the public health director. Definitely know we're in a work session. The work of Multnomah County's public health system is represented across the health department and particularly in the public health and health officer divisions, and it is vital for protecting the health of Oregon's most populated county. This budget presented to you today aligns with our statutory responsibilities and our unique governmental role as the local public health authority to stop infectious diseases from spreading, promoting health through community assets, and tackling the root causes of poor health. The Multnomah County Health Department serves as the local public health administrator, managing the day-to-day operations of the public health and health officer divisions. We know the people and families in our county need easy access to healthy food, safe neighborhoods, culturally sensitive care, and a protected environment. Next slide, please. So public health in statute is one of the only areas noted in state law with the daily responsibility of serving the entire population. For Multnomah County, that means we implement evidence-based practices through customized approaches based on the unique needs of community so that we can prioritize eliminating health disparities and the leading causes of death and disability while also protecting and promoting health for all 800,000 residents. These dot points on this slide summarize the statutorily required work of public health in Multnomah. But to depict how all of this works together, imagine this story. A new parent is referred from East County Clinic to home visiting services available to every new parent as part of universally offered home visiting. At that visit, that parent is connected to online vital record services and can order their new baby's birth certificate virtually. If needed, the new parent will get signed up for WIC and tied into county-supported breastfeeding classes and mental health supports for a new parent. They'll be encouraged to attend the People's Farmers Market and can pick up fresh fruits and vegetables with their WIC Farmer Market vouchers and can trust an enjoyable lunch from a licensed food cart. This young family will be getting the best start to health with support from county services and will also benefit from a neighborhood that is thriving with safe places to play and socialize, all critical protective factors in ensuring lifelong health and reducing chronic disease burden later in life. And to top it off, the success of that family will be reflected through aggregated data in our public health indicators dashboard, documenting where we are achieving optimal health for all and where we still have gaps for public health interventions to focus. Next slide, please. Last fall, the public health leadership team went back to public health basics for budget planning. We created a logic model for each program offer under ever-pressing budget constraints from the federal government, state, and local revenue decline. It required us to focus on what is uniquely our role that no one else can do and where we can move the needle on outcomes, particularly among community members facing the greatest disparities. Every program offer includes outputs or key items that you all are buying that we know are directly linked to short, intermediate, and long-term health outcomes that are directly related to reducing the leading causes of preventable death and are connected to one of the county's strategic plan goal areas. Next slide, please. Oregon's public health modernization is a statewide effort. Its goal is simple: to make sure everyone in Oregon gets the same core basic public health services no matter where they live. This system relies on coordination between the Oregon Health Authority, local public health departments, tribes, and community partners to build a strong defense against existing and potential threats. Our program offers in this budget are centered in Oregon's 4 foundational program areas: communicable disease prevention, prevention and health promotion, access to clinical services, and environmental health. Those 4 program areas are complemented with 7 foundational capabilities: leadership and organizational supports, community engagement, health equity and cultural responsiveness, assessment and epidemiology, emergency preparedness and response, policy planning, and communications. Next slide, please. To ensure financial and service accountability, and as a foundational practice for public health, we'll be tracking our budget revenues and expenditures to our outputs and outcomes through our newly created performance management system that starts with some of the outputs you see here on this slide. This proposed budget aims to stabilize the harm reduction clinic in East County and the STI clinic in downtown Portland, with staff moving between sites to support screening and treatment for common STIs, provide wound care, ensure that people who use drugs have naloxone to reverse overdose, and to refer clients to behavioral health or substance use support and other social services. In doing this, we are able to be open 5 days a week between the two clinics. The STI clinic specifically will provide confidential and culturally specific care for 3,700 unique clients and respond to 385 syphilis and HIV reported cases needing investigation. In addition to the 50,700 engagements for individuals living with or at risk of HIV, Hep C, or STIs through our harm reduction program, we anticipate our HIV Grants Administration program to serve 3,050 low-income HIV-positive clients in the region with housing referrals, transportation, oral health, and behavioral health services. As you heard yesterday from Director Banks and Deputy Director Henderson, much of what we do in the health department is to incubate and grow services and build that capacity in the community. And sometimes when we do that, we can let those services go and let them flourish elsewhere. This budget reflects that. In fiscal year 27, we'll continue to provide training on overdose response and prevention and be able to purchase and distribute naloxone for organizations and individuals working with high-risk community members. And we will continue to provide our brick and mortar syringe exchange services. These outputs will result in less disease, healthier adults, and fewer overdoses, which will directly contribute to increasing life expectancy and reducing inequities in the leading causes of preventable death. Next slide, please. Last year, I shared that investments in grants from the federal government would be a challenge, and that is still true today. Public health has been hit especially hard as this administration has a strong belief that state and local governments should cover public health functions, including emergency preparedness and response. Some of our grants were terminated early, others ended with no new funding stream to replace it, and some continue, but with the same or fewer resources as costs go up. I want to highlight just a few differences from the adopted budget in fiscal year 26 and this proposed budget. In the fiscal year 26 rebalance, we made adjustments to account for a loss in federal grants, including, but not limited to, the CDC racial ethnic approaches to community health and the vaccine portion of that grant, which was to specifically address the vaccine promotion and access for particular communities. We lost a Department of Justice, Bureau of Justice Assistance STOP grant, the school violence grant, and we also lost the Environmental Protections Grant addressing climate health. The State Department of Early Learning and Care reduced our grant for healthy families as a result of decreased state and federal investments, and our Care Oregon funds have been reduced. Making up part of the state funding on this slide is 38 different program elements from the Oregon Health Authority, with some increasing funds and others having small reductions. I want to call out and express my gratitude for the meaningful investments made with County General Fund to complement the state and federal investments. Where Multnomah County goes toward improving lifelong health and eliminating health inequities and the leading causes of preventable death, so does the state. Next slide, please. Also reflected in our budget adjustments from fiscal year to this proposed budget, from fiscal year 26 to our proposed budget for fiscal year 27, we are increasing the health licensing programs fees and the tobacco retail licensing fees. Fees make up 30% of our general fund total, so about $10 million from fees out of the $34 million. I want to point out it is currently cheaper and easier to sell tobacco and nicotine products in Multnomah County than anywhere else in the state. Lifting what Director Banks said yesterday regarding the years of life lost and the leading causes of death, we know that tobacco use still to this day remains the leading cause of preventable death in Multnomah County and in Oregon. The county's tobacco retail license fee has not increased since 2019. In 2021, the state passed tobacco retail licensing and grandfathered in Multnomah County's license, meaning that retailers in Multnomah County only need to have a county license. They do not need both a county and state license. This is important because the state license is more expensive than the county's. In fiscal year 2027, there's a proposed fee increase of $301 to align with the state's fee and to move the program further away from being dependent on general fund. The new proposed license will cost $984. Health licensing is back on track with annual increases to food, pool, and lodging fees with a 6.5% increase. Those fees cover the cost of implementing the program and reflect increases in operating costs. Next slide, please. I shared 4,006 or 40,006. 06. Sorry. No problem. I shared earlier a number of outputs this budget is buying. This budget also delivers on this immunization KPI. I'm calling attention to this KPI not because it is any more important than the rest, but because it is timely. This outcome is trying to capture the percent of children who receive a letter from the county about being behind on required immunizations, who then successfully submit a certificate of immunization status to their school within 21 days. And as a school board member on a neighboring district, this is really important to me because kids in school is probably one of the most important things we can do to assure their health. This is also a public health requirement through modernization and an Oregon state law. Multnomah County must annually compile and report the immunization status for all children attending a school, preschool, and daycare in Multnomah County. That is 761 locations and 108,900 kids that we're tracking on. The Public Health Prevention and Health Promotion team does this by first identifying all families in the county whose children do not have up-to-date immunization records on file at their schools. And then they mail letters warning that these children would not be allowed to return to school if their records are not complete before the February 25th deadline. For this year, this was approximately 4,600 letters that we sent out. On the right side of this slide, the measure on the right shows the percentage of children whose families received a letter and then were able to submit the proper documentation, allowing them to be in school on February 25th. This measure is not only a health measure, but it also, to me, reflects trust in public health, in the Multnomah County's Public Health Division, because it's a letter that people acted on. I also want to note, because I think this is really important, that less than 1% of all students are excluded on exclusion day. But we know every student counts, and we want them in school and learning, and that's why we do the work we do to close this gap. I also want to note, because it's timely, it's important to recognize the declining vaccination rates result in outbreaks that are very expensive. The recent Texas outbreak, with 762 cases, 99 hospitalizations, and 2 deaths, cost $35.4 million in total costs. And to put that into context to our communicable disease program offer, that program offer is $4.7 million. We're a bargain. As we speak, the communicable disease team and the very small but mighty immunization staff are investigating suspected measles cases right now. They're actively monitoring people who are exposed to measles and who do not have immunity, and they're referring folks to treatment. They're working closely with our neighboring counties, OHA, and healthcare providers to increase access to vaccines so they can slow the spread of the disease and keep kids and family members in school and doing the things that they love. Next slide, please. On any given day, name the challenge, but today I want to highlight 3 and our responses to them, particularly how this budget addresses those. To address the erosion of trust, we're prioritizing investments in foundational communication and community engagement capabilities. We're identifying community messengers who are often more trusted than government in sharing information, and we're engaging in platforms that the public trusts. And I just want to give a shout out to Dr. Bruno over here, who sat on Reddit with a number of our colleagues a week ago and answered kind of the stump the health officer questions on Reddit, and he did great. To address the resurgence of diseases, we're increasing investments in epidemiologists. We are leveraging health system partners to increase access to vaccines for all infectious diseases. And we have focused very seriously this year in stabilizing the STI and harm reduction clinics. To address climate-driven disease and injury shifts, we're investing in staff to look at healthcare data and the conditions that make people sick, to improve our community's response to extreme heat and to keep them safe. I want to note that since 2020, emergency room visits related to extreme heat have more than doubled. We are also investing in community-led data reports like the REACH Street Trust Transportation Report and working side by side with partners to lift community wisdom and strength so they can drive the solutions they want for neighborhood safety and social cohesion. Next slide, please. To do our best to have minimal reductions in services, we looked at all the ways to find administrative efficiencies. In doing so, there is little room left before we have to look more significantly at reducing services. Two examples of looking at efficiencies are in our harm reduction program and in our home visiting programs. To ensure we could stabilize the clinics, we further braided funding to support clinical staff for testing, asymptomatic screening, treatment referrals for care, for referrals for housing and other human services to be available 5 days a week, at least at one of those clinics. For this to be possible, we proposed eliminating the health reduction outreach team. What remains are clinic staff and our contracts with CBOs providing similar brick and mortar services. This results in a minimal, but no less meaningful reduction in engagements with clients. For our nurse home visiting programs, we reduced the number of staff focused on screening clients for services so that instead of each program having their own kind of soup to nuts screeners and monitors and trackers, we're combining all of those so that while even the programs have unique needs, the goals will be for the staff to understand all the programs and be able to get folks signed up to the program that works best for them. Each of these reductions also resulted in the loss of a program supervisor. Next slide. So the following 3 slides kind of break down what our reductions are more specifically. I'm going to summarize them by program area. For environmental health, we are going to lose one of our air quality program specialists. We're going to go from 2 to 1. The air quality position that remains will implement the county code regarding wood smoke ordinance, and will also have to serve as our air quality subject matter expert, along with the other managers in the team that also have that expertise. What we lose is the ability to rapidly respond to air quality inquiries like we have this year with the ICE detention facility and the air quality monitoring pilot we set up. We also looked for administrative efficiencies across office support staff for all of environmental health, so Vector, Vital Records, health licensing, and Healthy Homes. This resulted in a loss of positions that was paired with the loss of a program supervisor. Also reflected on this slide is what I've mentioned throughout this presentation. In a very difficult budget situation, we're proposing eliminating the harm reduction outreach team, and in doing so, we lose approximately 4,000 engagements with individuals needing harm reduction supplies and services, wound care, and referrals to behavioral health and substance use resources and other social services. We know that there are outreach services available in the community that can cover some of this need, reaching people who may not be able to come into a clinic regularly or easily. This reduction results in a loss of 5.8 FTE, one being a program supervisor. And I also want to call out in other funds under harm reduction, that is primarily the reduction in Care Oregon funds. Next slide. For communicable disease programs, this reduction is really a reflection of a pause at OHA and the CDC regarding our Mpox vaccine tracking until we know what they want to do, which I think we're going to be finding out soon enough. They want to continue, but not in time for this. We were kind of having to wait and that, so that's what that reflection, or that's what's reflected on this side. I also want to call out, while we looked at this program offer, we really needed to figure out how we're going to stay on top of the changing landscape of communicable disease spread. So we reevaluated the team, and we are adding more field epi capacity, and we've stabilized our nursing capacity so that we can be more nimble and flexible as communicable disease investigations increase, and the ability to manage a handful of diseases at any given time is our new norm. Also want to call out the new name change. It's no longer Program Design and Evaluation. We are now going to be EPR, or Epidemiology, Evaluation, and Policy Research. It reminds me of Scooby-Doo, I'm not going to lie. This much better reflects foundational capabilities identified in state statute. The reductions here are also things that we had anticipated, small amounts of money when grants end, and the body of work also ends with it. WIC reductions are a result of a program review looking for more efficiencies where we could find them. While no position is good to lose, we will continue to have capacity in all facets of WIC work. We will have fewer options for breastfeeding classes and support, and it may take longer for some to get a return phone call as staff may need to coordinate with translation services. Prevention and health promotion reductions are driven predominantly through our reductions in grants from the CDC. We've lost the CDC Prevail grant, the CDC Action grant, and we've received reductions in the immunization state grant. I want to note that some of this is still kind of lingering and folks might be making different decisions, but right now it's not anticipated that these funds are in play. Using our budget priority matrix focused on statutory requirements, equity needs to address the leading causes of preventable death, and priorities identified by community. So for us, we use the Achieve Coalition, the African American CBO Coalition, and the Youth Advisory Council. We leverage public health modernization and public health infrastructure grant funds to help keep some positions that would have otherwise been lost with the reduction of these grants. This is specifically true in maintaining our last two immunization-focused staff. In addition to the lost FTE, because of grant reductions, we did have to reduce some community investments, and that's going to result in fewer community walking audits, fewer referrals for produce prescriptions as part of the health-related social needs nutrition benefit, and possibly fewer CBO staff participating on any number of coalitions they currently participate on. Because we knew these grants were ending, we have been working closely with partners to prepare for their reduction. Next, and my last slide, but not least important. This slide reflects the reduction of funds in the Parent-Child Family Health Program. As mentioned earlier, these are a result of administrative efficiencies. In addition to losing the staff, this program is also losing a program supervisor. What is lost in losing that program supervisor is deep experience in Medicaid and third-party billing, which will be a loss for the program. However, the program is retaining a vacant program specialist with plans on bringing on a staff person who can support Medicaid and third-party billing needs. Thank you for your time and attention, and I'm happy to answer any questions.
Thank you. Appreciate the presentation. It's a lot of really hard cuts in public health. Do we, Commissioner Singleton or Commissioner Jones-Dickson, any questions from you?
So I just had a question about STI Clinic, and I think this will be a follow-up. I just wanted to understand, and Commissioner Moyer, I don't know if you plan to speak to this too, but I want to understand the difference between services from this current fiscal year and next year, and acknowledging that one of our partners with Cascade AIDS Project has had some reduction that could have significant impact. And so would just love to know broadly how we're thinking about that body of work. Again, understanding we're all operating under constraints that we wish we weren't.
Yeah, thank you for that question, Commissioner Singleton. And we can definitely follow up with more detail. What I really do want to say is, after experiencing that very challenging conversations that we had last year, it was so important for me to get these clinics stabilized, particularly in this last year. If you don't know, that Legacy Health Center they shut down 2 clinics in Multnomah County that provided about 15% of our STI screening and testing in the area. So stabilizing and making sure that we could function was really, really important. And again, we can get to more details, but it was a priority to try to take that one-time offer that we did have last year and think about how we could still support PrEP navigation, how we could still work with doing the patient navigation and doing the screenings. It's not perfect, and those nuances I know matter and are important, and I can get those for you.
Thank you. I appreciate that. And I will play out the whole tape, which is, I just wonder if at some point there isn't conversation to figure out across the system if there's a role for philanthropy in this work, since this federal administration seems so committed to gutting this really critical and important work under the guise of it being DEI, which we all know it's not. So that's kind of where I'm going, is if we can understand the system, begin to see if there's opportunities for advocacy elsewhere, should we need it. So thank you for doing that. And I also appreciate the work that has gone into trying to stabilize a number of the different programs in this budget. My other question would be, could you just talk a little bit about vector control and what vector control does, so that one, it's a bit of an odd name, and I don't know if everybody knows it, but I know we'll be having conversations about it as part of the capital plan. But it would be important, I think, for you all to share a little bit about the actual work.
Oh, thank you for asking that question. This is like historic, real bread and butter public health. I mean, this is where it came out of New Orleans, which is the home of public health work and sanitation work. Lots of bugs, right? Lots of bugs. So vectors, for those listening, the thing that can carry a disease. So mosquitoes, rats, number of things. You might have been hearing what's happening with hantavirus right now on the cruise ship. And actually staff that had to be immediately redeployed to get on some phone calls yesterday in regards to being prepared for that. So our vector program does amazing work, often not seen. And the reason they take up so much space is because they have boats, they have, what are the little flyy things, drones, they have electric bikes, because they go out and they spray where mosquitoes and their little babies like to live and hatch. They work closely with the cities to make sure that we have a right balance of rat population in regards, and then do a number of other things as well. And this is all entirely general funded. It is also required in state law to do. Real tricky thing, but an important body of work that takes a lot of time. And I will note that last year, a couple years ago, we found dengue as in Oregon's mosquitoes, and last year we know malaria showed up in Washington mosquitoes. And let's not lie, if they're in Washington, they're in Oregon, because Oregon's better. But anyway, does that help answer that question?
Mosquitoes don't know state lines? Is that what you're saying?
They don't.
It does. Thank you. I just wanted folks to be aware of what it does. I know because, again, it's close to where I live in district. And for those who don't know, St. John's, I'm not sure if it has the appropriate supply of rats, but that's an offline conversation that we can have.
I will say a really important, oversupply. A really important thing, if you go to the Blues Festival or any of our festivals on the waterfront in the summer, and you're not getting bit, you can thank this mighty vector team for that. That's why that is much more enjoyable than if we don't have a vector control program.
Thank you so much. I don't have any other questions.
I'll let somebody else go because I have quite a number of them. But I'm going to start with just some like pats on the back. It's a good way to start. So I would just want to really thank the Public Health Division for their clear and strong messages about the value of immunizations. I know from talking to people who lived in a different era when we didn't have some of the immunizations, the impacts of the lack of immunizations and the impact it had on whole communities, families, people's lives. And I think it's somewhat we take a little bit for granted now, all of those benefits. So I really appreciate public health being a strong advocate. I think we are a voice of authority and expertise within the community, and I think we've also done a good job. I know during COVID, when I was doing a lot of work with the school district, the work that the health department did with culturally specific organizations to share factual information about vaccines and immunizations was really important. So I just want to start with that. And the second thing is, you know, I always know summer is coming when I see Dr. Bruno standing by the river with a stethoscope, of all things. And I really appreciate that because I think sometimes we forget, you know, if you've lived here a long time, you just like, okay, it's nice weather, we got to dive into the river, but like there are precautions to take, so I always appreciate that, and I saw that the other day several times, so I was just reminded of sort of the value of also, again, providing factual information to the community that they can act on and protect people protect themselves and their families and friends. So thank you. So one thing, and this is somewhat, I'm not sure how it quite connects to the budget, but you brought it up in your opening statement, the whole issue of healthy food and how important that is as part of a healthy community and public health and community health. So I am wondering if you all are doing anything about the demise of grocery stores in East Portland. And that there are still some grocery stores, but there also is like less competition and just less. Because there's been a lot of large store closures. And when that happens, a couple things. I think prices go up, just like it's a competitive business. So if there's less competition, prices can increase. But there's just less healthy choices often. So then the choices become more processed food, things that are shelf stable, things that are like convenience store. So I'm wondering, and of course where those closures are happening are in neighborhoods with lower incomes. So what is the county doing about that? And do we have a point of view? And is there something that we could do to be helpful? Because it has been in the last year at kind of an accelerating rate to see those store closures.
Yeah, thank you so much for naming that. Your observations are things that our coalitions that we're supporting are absolutely interested in, particularly our REACH program, so the racial and ethnic approaches to community health. It's the A, it gets me every time. They have been doing these assessments. These walking audits are part of what they're tracking, not just safety of walking around the neighborhood and the street and crossing walks, but what do we see when we're in those, having those walking journeys? Do we have access to grocery stores? And they have raised this. They very quickly raised this when Fred Meyers was considering their closure out in East. They are very concerned about this. We certainly are interested and have been working on programs to build capacity for farmers markets, and we do have some small mini grants that we work with programs in that area. But the concept around what's happening with grocery stores and access, we are creating food deserts. Food that we aren't. Food deserts are being created in this county, and that is going to require a political response, a policy response to what that looks like. And I know our Achieve Coalition and the African CBO Coalition and even our Youth Advisory Group are all naming that as a real problem. So I would say yes, we are tracking it and we understand and we do have concerns.
I'm glad to hear you're tracking it. I would love to hear what, as a county, we can actually do to take action. I say the rate has accelerated rather dramatically. And it's places where I think we already have health disparities. So I'd love to move from knowing we have a problem, because certainly if you live in those neighborhoods, you know there's a problem, to what are the actions the county can take? Who are we partnering with? What sort of things can, other actions by others are taking that we could be supportive of? So I'd love to just get a follow-up on that.
Yep.
I'm glad it's on your radar screen. And then this is a little bit going back to the questions about the STI clinics and community services. This is program offer 4010. And it actually looks like there is an increase from 26 to 27. Is that because program offers were smushed together or something else happened? Because there's a small decrease in 411, which is slightly different, but in 4010B, it looks like it's going from 3.3 million to 4.5 million. So are there reductions because somehow the program offers are being offered in a different way?
We have done some combining of program offers, for sure, to make sure that when we have a program offer, it's telling the whole story of what that is purchasing versus in being in multiple. Part of these, and I can follow up with more specifics because this is just the highest level of overview, so we can provide more. But this really is thinking about how we blend services. So we have funding that comes in that was parceled out between STI clinic, harm reduction outreach services, HGAP, and what we're trying to do is bring those in a little bit, well, we had to. In order to leverage our local resources and our state and federal resources, we had to bring them in to focus only on the clinic side versus the outreach side.
Yeah, and this can be, since we still have additional time, this can be a follow-up, but I'm trying to reconcile slide 11, which shows reductions with the program offers, which show an increase. And again, I don't necessarily need to know now, but this isn't meshing. So I'm getting a lot of, and frankly, a part of the other issue is, of course, a lot of people are very interested in what's being funded. So people are looking at it and they don't understand what's happening. Of here are these reductions, but this looks like it's more. So I guess getting some granularity on what's changed year maybe at a line item, what's changed year from year, because I can't reconcile this, and I'd like to reassure people we haven't made a reduction, which is what the program for looked like, but that's not what I'm hearing from the community or what this slide seems to imply.
Okay. Yes, I can follow up with that.
Okay, with that, I'm happy to go, Commissioner Moore, if you want to go, because I have some more, but go ahead.
I'm wondering what the total loss of state and federal funds for public health have been over the last, I guess, year and a half, but particularly in this fiscal year. Why do you have tobacco licensing and not liquor licensing? Or do you, and then why do we get things from the sheriff on liquor license? I'm trying to understand.
Doesn't the state do LLCC license liquor?
Then why do we vote on it?
No, go ahead.
Go for it.
So we have tobacco retail licensure because that is county action that we've taken. I think part of we also have to approve licenses, but we don't actually, that's not a very satisfactory answer, so we can get more follow-up from you on that, but it's not, but our retail license, or tobacco retail licensure was like created and started here, and it's in the health department.
Yes.
Yeah, and so we act as like the regulator in the case of tobacco retail licensure, whereas in liquor, the state is the regulator, and you all have a approval role.
I don't know, maybe our county attorney knows why the board has to approve the liquor license renewals.
Thank you, Chair. Yeah. It's all in state law.
Oh, your mic.
It's all laid out in state law that the sheriff sends it to the governing body.
Are we preempted from increasing or doing an additional liquor license fee?
Off the top of my head, yes.
I usually, but, okay. Can I ask about the immunization targets? And although I'm thrilled we are not losing the ground that I feared we might, how does this compare nationally? And how, I'm not an immunologist, I feel like herd immunity is a higher bar than this. And so if we were to accomplish herd immunity, where would we need to be?
Yeah, great question. And Dr. Bruno could jump in here as well. But this measure, and it's a little funky because what it's really measuring is a subpopulation of a subpopulation of a subpopulation. So it's not necessarily measuring immunity or who's immunized. It's measuring of those who do not have their records on school, which is the state law. So this is our statutory responsibility. They haven't told their school, child care provider, or preschool, like, hey, here's my immunization records, or they have not submitted their exemption to that. That's what this is kind of tracking on. So our alert system is a statewide system that looks at vaccine rates, and we can look down in schools, we can look at county, we can look at zip code, we can look at a number of things. And for the MMR, which is measles, mumps, rubella, we're pretty high. We're in, I mean, we're not, we always want to be higher, but we're at 96% overall for the whole county for the first dose.
Okay.
94 for the second dose.
Yeah, 90,
Yeah.
well, we're on 90, I think, overall now for kindergartners because it's dropped.
Because so some schools have pockets. So one of the schools we just working in was higher. So that's immunity, right? This is a measure of are people getting their documentation in, and we're trying to keep them in school because that's so critical for kiddos to be in school. So this is to help us make sure that kids are getting in school. We'd like them to have the shot in the arm to be in school. So I don't know if that helps answer your question.
Under our public health authority, like during COVID, there were decisions made by the state related to certain professions, like you could not work in those settings without either additional PPE or being immunized. Do we have any of that authority? Is that purely the Oregon Health Authority's purview?
That is at the Oregon Health Authority. As far as I know, I don't see anything in our state statute that says we could make that decision.
Okay.
Just wanted to add, kind of a piece of what was happening in COVID too was employer-based decisions as well as state-based decisions. So, you know, there are authorities that you all would have as an employer as it relates to kind of immunizations. So that's just one kind of caveat piece that I would add.
I just bring this up obviously, there are targeted populations in which we want to make sure people get their immunization. School is certainly one of them. But there are members of our community who cannot be vaccinated or lose their immunization due to health condition or age. And there are settings that are particularly vulnerable that I worry about as the general population has had a real bombardment of, I think, not evidence-based information. I worry about those vulnerable populations. And, I think some people want to have a conversation about immunizations on an individual level and their rights, and are not understanding or appreciating their impact on others, and those who cannot make those type of choices and yet would be incredibly vulnerable in those circumstances. So I just think about that within the context of what's happening nationally, how we protect our most vulnerable, particularly since as a county we interact and provide many services to many of those individuals. So that was just part of that line of questioning.
I'm going to add one additional thing to that is I think the role of public health as a convener and as or the Board of Health as a vision setter. So while we might not have specific authorities over other folks, what we do use are the recommendations from a health officer, for example, for what to do in these vulnerable settings. And oftentimes we find that employers and other folks are working with us in that, also showing them the data, so that epidemiology function of, being able to tell people what their risks are. So that's some of how we try to approach it, even if we don't have a legal authority, but using the science, the convening power, the just, laying out for people what those precautions are for their staff and people that might be in their care are some of the tools that we use.
I'm excited that Commissioner Brim Edwards is being inspired by Mayor Mondani around starting, or at least having a conversation about food deserts, because that is a very real problem, and I think some people mock how serious that is for communities and don't understand why government would even have a conversation about access to grocery stores, but I actually really appreciate it, and I think it's important that people get how that has macro effects. It's not just, somebody might have to drive further, it really can have such a profound impact on public health in an area that has really restricted access. So I may joke about Mondani, but I actually appreciate the conversation because it's important.
So just to add to that, it's not just the closing of the stores, it's also, you add on top of it, TriMet changing their service, and lots of people who are using the grocery stores that have closed, using public transportation, so it's asking people to go further and further from their home. And so again, while it may be easy for people who have, multiple vehicles in a family and have the flexibility to go to the grocery store when they need to in their own car, and they can go outside their neighborhood, it's way more difficult for those who can't. So I had some questions. I think I'm just going to reference, I referenced them already. Let me find them. Just, again, there's lots of rumors floating around, not rumors, but just information floating around that just, I want to sort of ground some information, ground some facts. So in this year, in the program offer, the syringes, it was presented a little bit different from past years. In past years, it had the dollar amount and how many syringes, which it's a little bit harder to find this year. So just for the record, I'd ask about what is the amount for syringes in terms of dollars and the number, because there'd been a number floating around, like the county's spending $6 million on syringes, and it's just nowhere close to that. So do you want to share what actually is proposed in this next budget?
I sure do, and
Pulling it up too.
I'm like, somebody was gonna email it to me, and I'm like, where is it?
It's May 1st
110
at
I know it's
8:29.
$110,000, and it costs like $7 some odd for a case.
Yeah, it's 110,000.
I'm sorry.
Oh, sorry, I have my screen on. That's what this one has. I don't have the per case.
And then I think it's like $1 million. I so appreciate what you're doing, because I do want the public to hear this. I can't find it to read it.
Do you want me to read it?
I think.
The
Please.
answer is.
Thank you.
The answer you gave me was that because I heard this number of like $6 million. The answer you told me is there's $110,000 allocated for syringes distributed, to be distributed by the county, which is 1.43 million syringes. I also asked about the exchange, which I thought was useful. It's not where I'd like to see it, but it's not an insignificant number. Do you have those there, or do you want me to say what they are?
I know what the ratio is.
I feel like I remember it's 800 and something.
Yeah,
Yes. 2 million of the 2 million distributed, 800,000 are exchanged. I think that's 800,000 that aren't out in the community. I also want to note that you said that you provide clients with safe disposal boxes so they can easily dispose of used syringes at larger disposal boxes near to where they live and more timely than needing to wait for a clinic to open. In addition, Metro and the county has worked to ensure a number of safe syringe disposal boxes are located throughout the region so people can dispose of syringes in a timely and safe manner. I know the libraries outside the county building, there is one as well. So again, just want to share some factual information. I have to ask the question I ask every year. I'm assuming the county's not distributing foil and straw?
No. No.
Okay, thank you. Then, this is a little along the whole issue from the conversation about enforcement this morning. I'm thinking one county and even like one department. So I was part of the discussion that we had about the health department with health inspections of restaurants and food carts and everything else. And there was, we need to raise the fees because part of our mission of making sure that people are complying with health standards is we need to do inspections, which to me is like enforcement. So I'm curious, I was a little bit disheartened of, it seemed like a reluctance of like, this is something that is a health hazard, that the county would be reluctant to enforce or feel like it's not its role or this is less important. There was a pretty vigorous hot dog stand enforcement mechanism for a while by the county with the city, by Providence Park. And so I guess I'm curious about, so like the different standards. Is it like the money's available for that? Same thing with the tobacco, like fees, like the money's available, so we feel like we can enforce it, or is it something else? Is it just purely like we need to have make sure we have the money so we can do it, or is it something else?
Well, thank you for that question. So for health licensing, those fees that enforcement can only be used for those things, and same with TRL. So that licensing system generates a fee system that then can help us license that. We don't have that mechanism for enforcing what was talked about this morning. So that's I would say, the difference.
But if you had it,
But if I,
so it's a funding. Yeah.
I would say that, yeah.
Yeah.
And also, we want to do a good job.
yeah.
I think that's the thing that I want to say too.
I think everybody wants.
Right,
What's that?
because we know that when we have laws that when we're the enforcers from the experience, folks want to see something done about it. So if they call, they want a response. If they, they want to understand how we've tracked, if someone calls and says there's something about like this food place, we want to be able to say that. So I think, the differences are there's not as easy of a funding source, but we wanted to show with you all as the board what we think it would cost to set up an enforcement mechanism that meets what our standards are for enforcing something, which is, doing the follow-up and having the ability for it to be easy for folks, having multiple languages, being able to have the materials to educate so the problem stops, those different things.
And actually, this is sort of a separate problem that I want to try and approach, not necessarily through this budget cycle, but it's really the 1,200, the 1,200,000 of used syringes that don't get returned. They're just all over the place. My sister for a long time had a downtown, a business where she did plantscaping downtown, and that's often the receptacle of where people put used syringes. So as I said this morning, this isn't the prohibition around schools is not the solve for, but I do think from a public health standpoint, to have 1.2 million used syringes, just not saying they're all out there, but a lot of them out in the community in places where you also, your opening statement talked about safe places to play, and I think those are things we should be thinking about longer term of how do we also address that. So more to come on.
One of the things I would say about that, absolutely. And the reason that there's some of the boxes out there is because that was kind of us engaging and like, here's this problem of syringes being on the ground and engaging with another jurisdiction, from my previous work here and previous roles. So I think, absolutely that's a part of it. And I think kind of earlier, as I heard Kirsten ask, kind of like us wanting to understand kind of like the multiple problems that are probably involved in what are this issue is kind of, and then matching some strategies to those, and part of that strategy is people having other places to be, or we could love to have a conversation about that. The other thing I would say is because people have multiple different places to discard of their syringes, we don't think it's 1.2 million that are out there, but we're also not, there's other people who are collecting some of those, but there is, what we know is, there's obviously from folks seeing them on the ground, there's an issue that needs to be solved for, and we are happy to be a part
It may
of
not be 1.2, but there's a lot.
There's more than what we want.
Yeah.
So, sorry, and I want to continue this. I just want to do a time check because we have about a half hour left and we still have one division still to do for the health department. So just time check. Okay, go for it.
Yeah. It is actually very difficult for regular people to dispose of syringes. I think, yes, there is the use of syringes for drug use, and then there's the tens, if not hundreds of thousands of people who use syringes for a variety of different health-related reasons. Do we have the regulatory authority to require those who sell or disperse medications that come in syringes or need to be administered via syringe to be a disposal site? Like, I think about insulin or GLP-1s, or there's a whole list of things that are just very, very common. And like fertility treatment, good Lord, if you've ever gone through that, is there an unbelievable amount of shots you're doing, of which I have done and has my wife. And it was actually an issue because you don't want to just throw syringes in the trash. That's unsafe. And those boxes are actually not that cheap to get the things. So I want to know what our options are, because I think the syringe issue, yes, there is clearly a public syringe issue, and I'm not trying to conflate them, but I do think like it's not actually super easy for regular people to figure out how to safely dispose.
We'll have to get back to you on that.
Do we have any questions from Commissioners Jones, Dixon, or Singleton online?
I already asked my questions, Chair. Thank you.
Okay, thank you. And Commissioner Jones, Dixon, I think your hand was up before, but I wasn't sure if that was for this section or not.
Yeah, no questions. I was just going to let Commissioner Brim Edwards know, check out the amendment that I submitted yesterday regarding the food deserts.
Great.
Yes, but thank you.
All right, thank you.
So I just a reminder, I had one last, I know there's a bunch back and forth, but I had one last set of questions about the Care Oregon distribution. So I'd love to get that both as part of the budget process, but also for the ordinance.
Thank you. Can I answer one more thing about your question? Because it was about the food thing, and I just want to follow up. I did get a really quick response on some of the things we are doing regarding food, and that is working on healthy with retailers to think about how they can invest in, it's not the big grocery store, but how do we help smaller retails invest in refrigeration systems or systems that help them be able to affordably purchase and hold and refrigerate fresh fruits and vegetables in different locations. It's not a total problem solve, but that is something that we are doing. So I did want to give a shout out
It's
to our
probably going to be a
folks.
whole host of things that we need to do.
Thank you so much for that very thorough presentation. Lots of good back and forth with questions too. Thank you so much, Kristen. We'll turn it over to you, Bruno.
Great, thank you. Good afternoon, everyone. I'm Bruno, he, him pronouns. Your deputy, no, I'm the health officer, not the deputy health officer. That's Therese Everson, who's not here, is our deputy health officer. The two of us, along with our deputy health officer, Paul Lewis, serve your pleasure at Multnomah County. I'm here to talk about the Health Officer Division, which is made up of 4 different programs performing statutorily required work that's closely related to the work that you've just heard about in our overall health department and with our public health division. Our division manages, next slide, please. Our division manages several non-discretionary functions that Multnomah County is legally required to perform as a local public health authority, whether it's the health officers providing physician consultation under ORS 431, the medical examiner's office that investigates every suspicious death under ORS 146, our emergency medical services, planning, coordination, and medical direction under ORS 682, or exercising the public health emergency preparedness plans and responses under ORS 431. These are roles that no other agency or partner in our community can fulfill. The medical examiner's office is on the front line of our public health data collection, and while we saw a glimmer of hope in the 18% decrease in overdose deaths in 2024, our workload has expanded significantly due to the state's shift of investigative duties to the county, and our request is to maintain a 2.0 FTE added in FY26. That's critical to ensure that we meet our statutory duty to the community and our justice system. So next slide, please. You have the FY26 and FY27 grants and county general fund aggregation for the division, and I'll talk for a minute about what goes into each of these aggregate numbers. A fairly significant portion of the county general funds in this case are ambulance franchise fees, EMS medical director fees, and EMS joint training fees, and ambulance licensing fees. These are fees that are only collected based on what the county spends on performing these functions, and this accounts for a little over $3 million in the general funds. Federal and state funding is comprised of 3 fairly distinct buckets. 1.4 million of state funding is solely funding the Tri-County 911 program within the EMS part of our role in stewarding appropriate use of our 911 medical system. A little over $400,000 is our intergovernmental agreement with Washington County for health officer services, and the remaining approximately $300,000 are federal pass-through grants that now entirely fund public health emergency preparedness and response. Of note here, there are no changes to the fees. Ambulance licensing fees have been $250 per vehicle since 1995. The ambulance franchise fee and medical director fees are reimbursed by the EMS agencies for the county's actual expense for these services. And the joint training fees is a fixed $175,000 per year as a contractual payment from the ambulance vendor, which serves as a pass-through to promote multi-agency training for medical care. We do have an upward trend in FTE and budget for the medical examiner. In FY25, the state shifted full death investigation responsibilities to the county, and we are concurrently managing the persistent volume of the fentanyl crisis. We reallocated unbudgeted resources to add 2.0 FTE medical death investigators to ensure we can meet our target of 1,550 in-person scene responses, a critical performance measure for public safety and preventable death data. We have a downward trend in both budget and FTE for public health emergency preparedness that reflects a total reduction of $90,000 and a total of 1.08 FTE. As federal grant funding through the Public Health Emergency Preparedness and Cities Readiness Initiative grants becomes more constrained, we continue to decentralize public health emergency preparedness activities and programmatically focus on core statutory call-down drills and exercises. Next slide, please. On the health officer mandate, our clinical leadership is a statutory necessity under ORS 431. This isn't just administrative oversight, it is the legally required physician authorization that allows the health department to operate its clinics and fulfill its role as the agent of the state in enforcing public health laws. And without this medical direction, our ability to legally provide direct clinical services would cease. The health officer team provides essential clinical direction that allows our STI clinic, harm reduction clinic, and tuberculosis programs to operate. Next slide, please. Our key performance indicator I'd like to highlight is the target of having 100% of our communicable diseases events be consistently coordinated according to our response protocols. Our Tri-County health officers have ensured that this has happened every year, and it happened over this fiscal year, and are committed to consistent coordinated responses going forward among our county communicable diseases team, our communications team, and our OHA partners. Next slide, please. The FY27 budget for the Health Officer Division signals a continued transition from reactive crisis management to proactive system stabilization. The shift toward permanent clinical quality improvement leadership in EMS and the expansion of the medical examiner's office are necessary structural responses to the new normal of high complexity public health management. However, the reduction in Tri-County 911 services for non-Medicaid patients highlights the sharpening of the social safety net as the general fund has contracted. Furthermore, the vulnerability of the Medical Reserve Corps demonstrates that the pandemic era volunteerism is waning, requiring the county to invest a full-time dedicated professionalized internal management to maintain its disaster resiliency. As grant funding fluctuates and our Medical Reserve Corps volunteers face dwindling support, our department is exploring the creation of a dedicated health department emergency manager. The success of this division in the coming fiscal year will be measured not only by its response times and investigative speeds, but by its ability to translate medical examiner data into actionable policy and focused interventions that move the dial on health inequities. Next slide, please. The state statute, ORS 682.062, directs counties to develop an ambulance service plan for all areas within their jurisdictional borders. An ambulance service plan specifies how the key features of the emergency medical services system are structured within the county. Multnomah County is statutorily obligated to assess the county's ASP and, when significant changes occur, to revise the plan. This process of assessment, reviewing recommendations, and ultimately making revisions to the county ASP would result in a procurement for the services described in the plan. The $362,000 one-time only request for continuation of the ambulance service plan is a critical investment in our infrastructure. Our current plan is nearly a decade old and no longer reflects the challenges of our current healthcare landscape. So this funding allows us to continue the project authorized and started in 2024 as a comprehensive reassessment and initiates the procurement process that prioritizes reliable, equitable response times for all residents. Required new procurement must be completed and in place by September 1st of 2028. The Health Officer Division remains a vital clinical conscience for the Multnomah County, and in a year defined by fiscal austerity, the division has prioritized the legal and medical foundations that protect the life and health of every resident. Thank you so much for your attention. I'm happy to take any questions.
Okay, thank you so much, Dr. Bruno. Any questions on the health officer?
Yes. Related to, well, I think it's you, it might be a little bit of both. in emergency response, what is our obligations if, to our community, if a disaster were to pose a significant health threat to a significant portion of our county population? What is our response under statute? What are we supposed to do?
Yeah, it's a great question, Commissioner. Oftentimes, we are planning for these types of events all the time. We're doing exercises to prepare for disasters, catastrophes that may occur. Our role is really in sort of convening, whether it's with our neighboring counties that also may be affected, whether or not we need to pull in mutual aid to help support the necessary response, working with our state, Oregon Health Authority. But it is a central role of ours to play in helping coordinate a lot of that response, and especially with our emergency management department as well. So it's a coordinated effort across our divisions, and we play a central role in that, yes.
Yes, and I would add that public health in particular, so the joint work that we do is focuses on ESFS 8, which is, I do not know what the E and the S and the A, but thank you. Which is, depending on what the emergency is, if it's communicable disease, it's anywhere from quarantine and isolation and all of the guidance that happened during COVID, to assuring clean water, wraparound services. How do we keep people safe where they're at and able to function? And so what does that look like to get resources and supports to them, to facilitate that at the very least? And then Dr. Bruno, like he had said, but I think is really important to double down on, is that required coordination among the healthcare systems. So if one hospital is experiencing a huge boost because they're where the emergency had to get to first and this one is free, Dr. Bruno is going to help facilitate that understanding so we can move the ambulance services around, which is a really important benefit to the people of this county.
I would also add, this is just a little bit from the presentation yesterday, that we act as public information officers, working with other counties and getting information out. We, as it relates to providing health care for our clients in various areas, have that responsibility. Those are some in our integrated clinical services or our corrections health. And then from an operations standpoint, like Valdez's work that it was talking about is doing some of the planning across both the department and then working with other partners as well. So several different roles that we would have in an emergency, including letting people know what the health harms are, taking care of them if there are health-related impacts, working with the system to make sure that the resources are in the right place and doing that convening, which is really important.
One of the issues that came up, and we passed a resolution, was, what would be the resources necessary for not just a health response, but including a health response, if there were to be a disaster that involved storage of very dangerous, either petroleum products or chemicals or all sorts of things. We're talking about the CEI hub. I think, I don't know if there is other large-scale storage of profoundly dangerous chemicals elsewhere in our county, probably. Where are you in that work, and how, I get our coordinating. I always think about Katrina, and I always think about, you could have coordinated the hell out of that. There were people who didn't have the resources to leave. Or there were people who had disabilities that could not get out. And so I guess my question is, what do we do? Or do we not? Because we don't actually have the money to do anything.
Great question, complex, probably lots of different answers, but one thing that I do want to highlight is, as part of public health modernization, we were required to do an assessment across the entire system of public health in Multnomah County. And in that assessment, it was definitely identified that emergency preparedness is not a strength that we have. It's not zero, but it isn't a strength. And we had to submit to the state what we were going to do to mitigate that. And again, doing this in constrained budget environments, we couldn't throw in that we want to hire 100 people. So some of the things, yeah, win the one, which is really important. And then certainly Bruno's team. But the other things that we're working on is how do we have people understand an emergency of that magnitude, all hands on deck? And so we need a workforce that's ready to respond to that, to understand what their roles would be in that, to understand, to prepare in continuity of business operations, what we will have to set aside so that we can address that response. Those are all things we're working on this next year. This is part of, actually, it's part of a 4-year plan. But those are things that we're working on. They're not the silver bullet. But they are things that we can do with limited resources in helping people reset on what their role is, whether you work in WIC or whether you actually work in emergency preparedness, that we're all going to contribute to something of that magnitude.
All right, any questions for Dr. Bruno from online?
None for me, Chair. Thank you.
Same.
Okay, great.
I've got one.
Okay, great.
And since I already gave you your flowers, sorry, it's premature. I'm not premature, but like you got it early. So, good job. I have a question about the ambulance service plan. And I'm looking at the program offer. So this is a general fund ask of 362. It looks like it's a combination of personnel, is that an FTE, and also contractual services?
That's right.
So I'm going to focus on the contractual services. So it's 190 being proposed for this year. It was 200 for last year. But in the program offer description, it says, in 2024, the county EMS program began a comprehensive ASP assessment. Do you know how much we paid in 2025 for either contractuals, for any contractual services?
I can get you the exact number. I don't have it in front of me, but yeah, that was sort of the initial payment to the contractors. And this is, for the ongoing work. This 362 is part of that ongoing work.
Is that customary for something to take for us? So say if it's a similar number from the past years, it would be almost $600,000 over 3 years. Is that like the normal length of time it would take to do a revised ambulance service plan?
It is my understanding, due to the comprehensive nature of the work and the assessment, meeting with different interest holders across the county, and relying on the expertise of our consultants.
And just in fairness to you, I know you weren't here the whole time.
Yeah, it's true. Yeah, it's my first time doing it, but that's my understanding of when the last time it happened in the 90s, is that it does take a sort of a comprehensive review to ensure that we're finding the best recommendations, vetting those recommendations, and then making those recommendations to you all. So we'll be actually briefing you a couple more times this year. We have some upcoming briefing sessions, so we can kind of go through what those recommendations are for your approval.
So again, it's fairness to you. I know you're the person here now, but I've been here through the budget allocations over the years. So if you could share with me sort of like the total cost of the project.
Yes.
That would be helpful, because it looks like we've had at least one FTE at 190 or 171, depending on the year, committed to this project as well. And I'd love to understand the total cost to us and how that compares with others. It seems like a lot, and it seems like a long period of time, because 3 years, that's almost, it's 3 out of the 5 years for the contract extension we had. And I know the contract extension happened before I got on the commission, but literally it was a consent item. And so I'm just curious about the amount of work and what we're getting for a lot of consulting fees, especially when it's coming out of a general fund. And then my other question on that particular item would be, so we have internal staff, contractual staff, and then also by ordinance, we have a group of outside experts that are on this. I forget their exact name, but they've only been convened once, and I'm just wondering how they interact with or help us do our job in terms of developing the ambulance service plan.
Yeah, it's a great question. Yeah, so you're referring to the EMS Advisory Committee.
I forgot the name. Yes, thank you.
That's correct. Yes, we did convene them. It's a group of local experts, and then the consultants have also been convening various other agencies and consulting with them to get their input on where they see some of the pain points and recommendations. They've compiled a list. We're in the process of kind of reviewing that list with them. They were actually in town this week, and we were able to review a lot of the nuances with them, specifically about which one of those set of recommendations, going through feasibility with cost, and to determine kind of what are going to be the ones that we make recommendations to present to you all as a board.
Yeah. I'd heard, and again, I always want to have the facts, that they'd only been convened once. So I'd love to get sort of just the overall project plan, just given, I mean, if everything had worked well over the last several years, I wouldn't be asking you all these questions. I mean, just want to make sure that we have a plan that's going to get us ultimately an ambulance service plan that provides good service at a reasonable cost to the county. So I'm interested in the process by which we get here, and also just in times of budget constraints that we're doing it in a fiscally reasonable way.
Yeah, that's fair. Yeah, happy to get you the proposal and the plan, timeline, and budget for that.
Great.
You got it.
Thank you.
No problem.
I think that's all the questions we have then for Health Department this afternoon. Thank you so much for the multi-day presentations, and we will let you know if there's a need to come back to answer any questions, but I know that there's a lot of questions in writing that you guys are going to be following up with. So just appreciate all the work so far on this.
I say thank you to you all for your just engagement with all the information and all the words that we brought you over the past couple of days. Appreciate it. We like talking about our work, so
Yeah.
thank you.
You guys should. You did an amazing job. And
The health department is now even more important than ever, just given the lack of leadership at the national level. So you have a very important job in terms of protecting our community in the absence of any sort of federal protections or federal guidance that are based in fact.
That's why I'll be proposing an amendment for universal health care.
Yay! Oh, Valdez is like standing O. So, thank you all very much. Before we bring the afternoon to the close, are there any budget amendments or notes that anyone is bringing forward today?
Yep, I have one.
Okay, we have one. Go ahead.
I will send electronic copies around. So this is an amendment to restore employment programs connected to homeless services. We've had a lot of discussion about this, and to maintain service levels for employment programs that support people experiencing or at risk of homelessness to earn income through employment, developing work skills, and establishing work history. This is, as I've said many times, this is a powerful way to empower people, to give them agency, to earn funds for housing, life's basic expenses, build a path for greater self-sufficiency. And it's not completely paid for, but it's more paid for than the other ones. And I will, as with all my amendments that I've introduced so far, have had that paid for. This is almost all paid for, but I have a little more work to do. One, it's actually taking, this is savings like I did last year on sort of the delayed hire on the vacancies. So more details on that, but not everybody hires, most people don't, most departments and divisions don't hire people on July 1. And then second, the other piece of funding is taking $1.4 million from HSD program 30100, and I'm going to spend just a few minutes explaining why I'm using those funds. So the county maintains video lottery funds in a dedicated separate fund. The county receives these funds as a pass-through from the state with statutory requirements specifically for economic development. Video funds have been used to support employment programs last year, which directly support people experiencing or at risk of homelessness to earn income through employment, developing work skills, and establishing work history. In FY26, it supported $2,733 million and $270 in funding for employment programs. This is a key and direct economic development activity. So it is moving. I'm concerned that this was moved out of what I consider to be employment, economic activity related funds, and moved it somewhere else. So this is, I think, much better aligning the directed use and the statutory requirements of these funds than what is currently in the budget.
All right, thank you. Any other budget notes or amendments? All right. Thank you, everyone, for the great work today. That concludes today's budget work session. There being no further business, we are adjourned.